Welcome to Alzheimer Speaks Radio. I'm your host, Lori LeBay, and I'm so excited that you're joining us today. We are going to have a fascinating conversation as usual as we learn from people all around the world at all ages and stages of life. Stay tuned as we shift our dementia care from crisis to comfort.
Here we go. What you think about, you will bring about. Dementia change. We will.
Well, hi, everyone, and welcome back to Alzheimer Speaks Radio. I'm your host, Lori LeBay, and if you liked our opening music, it's called Clarion Call by the Mark Arneson Band. And you can download that on any of your favorite music platforms. For those of you that are new to Alzheimer Speaks Radio, we are about sound information, not just sound bites. We want to have real conversations with real people all around the world, voices big and small. So maybe, just maybe, you can be our next guest. I'd love to hear from you. You can just email me at radio@alzheimerspeaks.com. Now, before I introduce our guest, I'm just going to do a couple of housekeeping things. One is to mention Dementia Map, our global resource directory. We would love to have you check this out. We're expanding it every single day. So if you have a service, product, tool, or knowledge base, you can enter it for free. Or we also have some enhanced plans that allow you advertising, blog posts, banner ads, and so much more. So again, go check out dementiamap.com. And for those of you that are looking to be part of a research trial, now you can join an important Alzheimer's disease research in just minutes from your home with Picnic Health. So go to picnichealth.com/speaks to sign up and get $25 just for signing up. Picnic Health collects and digitizes all of your medical records into one online account. And you can share that anonymized data from your records with medical researchers. And by examining this real world data from medical records, the researchers can find answers that they couldn't find in normal clinical trials. Now, I also want to mention a couple of events. Plymouth International has one more session in their virtual dementia conference, which is challenging and finding solutions to this world we're living in, COVID. And that is November 10th. Also, Arthur's Senior Care continues to sponsor our Arthur's Memory Cafe, which is held the second and the fourth Wednesday of each month at 1 p.m. Central. So that's 2 o'clock Eastern. It's virtual, so anybody can attend. And then Brookdale North Oaks is sponsoring our Caregiver Connect support group, which meets in person for people caring for a loved one with dementia at 10 a.m. the last Wednesday of each month, and that is held at the Shoreview Community Center. So go ahead and check those out. You can always reach out to me at radio@alzheimerspeaks.com for more information. We are going to hear from the Footbar Walker, and we're going to be right back.
Introducing the life-changing Footbar Walker.
I'm Peggy from Danville, Kentucky, and I'm 91 years old. The Footbar Walker revolutionized my care of George. It absolutely benefits the patient and the caregiver both, and that's the beauty of it. It's so easy to use. It folds up just like a dream. I got it in and out of the car without any effort at all. The saving that I made from having to put him in a nursing home came to about $192,000.
Does someone you love use a walker? Do they struggle to get up from a seated position? Are you a caregiver dealing with physical pain and stress as you help your patient? The Footbar Walker was designed to assist not only the patient, but also the caregiver. Patients have more control standing up, and no lifting from the caregiver is required. See how it works at thefootbarwalker.com. That's thefootbarwalker.com. Peggy, would you recommend the Footbar Walker?
Do I ever? I would not be in the health that I'm in today at this age had it not been for the Footbar Walker.
Okay, it is now time to introduce you to our guest today, who is a very good friend of mine, and I'm just thrilled to have him with us. Eilon Caspi holds his PhD, and he is a gerontologist and a dementia behavior specialist And now he is the author of the brand new book, Understanding and Preventing Harmful Interactions Between Residents with Dementia. And he currently works as an assistant research professor at the University of Connecticut. Eilon's applied research focuses on improving and understanding the prevention of various forms of elder mistreatment in long-term care homes. Some examples are like injury and deadly neglect, fatal resident-to-resident incidents, financial exploitation, and theft of opioid pain medication. In Eilon's free time, he enjoys carving wood, including a brain hemisphere, which was just magnificent, and educational signs such as See Me, Not My Dementia, and Justice for Elders. So please help me welcome Eilon Caspi to the show. Well, Eilon, I am so excited to have you on the show today. Your book has been in the making for a long time, I know, and I know that is just a huge piece. And so I'm so proud of the work that you've put into to come to this space. I haven't written a book myself, but I've heard from other authors what it takes. And like I said, I am so excited for you to get your work out into the world in this format. So first of all, thank you for taking the time to be with us. And second, before I get into my line of questions, I always like to ask everybody to share if they've been personally touched by dementia in their own family or circle of friends. It just kind of gives our audience a little base.
Sure. So first of all, thank you for inviting me to talk about this book project. I really appreciate that. I will say that if you know somebody who wants to write a book, 10 chapters on her own or his own, send them to me first, and I'm going to talk them out of it. Or they'll have a better sense of what they're getting into, because I certainly have a humble appreciation of what it takes after several years in the making. So with that, of course, I'm thrilled that the book is out, and we're going to talk about it in a minute. The culmination of 13 years of work specifically on this phenomenon. But just to answer your question, both of my grandmothers lived with dementia in the final years of their lives. So that's how I first learned about cognitive disability in my family. And so that's the initial connection, the personal connection with dementia.
Okay. Well, I want you to share with us kind of what led you to write your book, which is entitled Understanding and Preventing Harmful Interactions Between Residents with Dementia. There must have been a trigger point that said, okay, I'm going to go down this path.
Absolutely. So while I worked as a nurse aide 27 years ago in a nursing home where my grandfather lived in Israel, I noticed those interactions between residents with and without dementia. Later on, I also saw those interactions when I worked in a nursing home as a social worker in the city of Jaffa in Israel, with elders who are with low income, many of whom with dementia. But it was really years later, in 2007 and 2008, nearby Boston, when I did my doctoral dissertation study in 2 secure dementia care homes, and where I conducted the equivalent of a 1 year of direct observations on the lived experience of people living with dementia in those care homes at all stages of the disease. And what I noticed is that these episodes occurred on a daily basis, and they caused a lot of frustration, distress, fear, and also many of them were risky for the safety of these vulnerable, many of whom physically frail individuals with dementia. So when you see this phenomenon occurring on a daily basis and the impact that it made on residents and staff and family members, it leaves an impression on you. And I decided to focus on this phenomenon in a more meaningful and structured way during the study itself, and then in the years since then till today. I have to say that it was quite a journey. It was I learned a lot. I still learn a lot every day about this phenomenon. I do not have all the answers. Every time there's an injurious or deadly incident, I'm learning something new. But I'm just thrilled that I have opportunity to share what I learned with care providers, whether it's nursing homes, assisted livings, direct care staff, nurses, social workers, and administrators, how to address these episodes, how to prevent them, and enable the residents to realize their right to remain safe in their care homes.
Can you give us an idea, when we talk about understanding and preventing harmful interactions, can you give us maybe just a couple of examples from everyday to extreme so people know what we're talking about here?
That's an excellent question. So first thing I would say is that the spectrum of severity of these episodes is anywhere from mild to dangerous. But by dangerous, I mean it could be physically injurious and also fatal. When you look at the common circumstances surrounding those episodes, some of the common ways in which they take place have to do with the fact that it is often the case that a large number of elders with dementia share a small living space. I'm talking about public space, but also bedrooms. There's a lot of people who share a bedroom with a roommate. And not only that, they share a bathroom. And they have a serious brain disease, a cognitive disability. And many of those settings are secure. And so there's a lot of possibilities for invasion of personal space anywhere in the care home. And also what I call unwanted entries into bedrooms and bathrooms. And so it is easy to forget that this is their home and that their bedroom is their last frontier of privacy. But for some reason, historically, we know the reasons. We have 2, 3, sometimes 4 people sharing a bedroom, and several residents may share a bathroom that is adjacent to their bedroom from 2 bedrooms sometimes. And so there's a lot of invasion of personal space. There's unwanted entries into bedrooms and bathrooms. And then there's a lot of situations where residents with dementia will get into a situation where there's a simple misunderstanding, interpersonal stressors and frustrations that when staff are understaffed. First I should say that care staff, the vast majority are caring and loving and dedicated and hardworking and underappreciated and undertrained. And they're overworked and they're busy. And many times they may be in a different part of the care home, not in a position to detect the early warning signs. And so they may be providing personal care inside a bedroom when 2 residents are fighting over the remote control in the TV lounge or in the dining room. And so there's a lot of opportunities for these episodes to occur. And all you need is literally one push. Because if you would push me, I might be able to, I may fall down, might be able to block the impact with the floor. But when you are an 85-year-old person with dementia, or we know are higher risk of falls before this phenomena, or before talking about this phenomena, with a walker or without, they often fall and they break their hip, or they have a brain trauma, and then their condition deteriorates, their physical, medical condition, and then there's medical complications, and they may not recover from that. So these are some of the circumstances that often occur in care homes, whether it's nursing homes or assisted living residences.
You really made me think, when my mom first moved to the nursing home, she was in a bedroom with 4. And I'll never forget one episode where one of her roommates was in the bathroom, and she was having some issues in there, and the whole room stuck. I mean, it was horrible. But my mom had no filters at this time. And so my mom was just screaming at this woman, which was totally not her previous character behavior. But when you were talking about that, I just thought about even the design of the building. How dumb to have the bathroom right by the door. So if someone is making noises or having odors, everyone who goes back and forth instead of putting it in the back of the room. I mean, and everyone's bathroom etiquette is different. Some people can sit in there with the door open and it doesn't bother them. So when you were talking about the privacy and even the clickers and all of those types of things, it's like, oh my gosh, there's such a wide range of where everybody is coming from with etiquette in private space. And I think so often we just think, well, it's no big deal. It's kind of dorm style and everyone will adjust. Well, they can't. Mm-hmm. They don't have that capability. So thank you for pointing those examples out.
Can I give an example actually from Dr. L. Power?
Sure.
So he gives this wonderful example that, kind of brings home the message of how as a society we're even accepting those living arrangements, right? So talking about dignity and safety. So he gives the example of, imagine that tonight, 9 p.m., you're sitting in your home, somebody knocks on your door, you open the door, you don't know this person, the person doesn't say a word, the person walks with a mattress into your home, walks to your bedroom, puts the mattress on the floor next to your bed, and tells you, I'm going to live here until the rest of our lives, until one of us moves on. For some reason, we somehow learn to accept that it's okay to have 2, 3, 4 people together in the same room. Now, I have to qualify that because there are people who enjoy having a roommate, the companionship, the emotional support. Residents in early stage of dementia, very attentive and compassionate, and frankly helpful in circumstances where staff are busy. They may alert staff to a need, a medical need. So they may press the button and it could save lives. So we need to use a balanced approach. And I don't want to go too much into solutions at this point. We'll talk about it later. But I think that we need to take a step back and think about what's the vision for the dignified and safe living. And I think the pandemic, not only the injuries that occur between the psychological harm and physical injuries and fatality that occur between roommates and those unwanted entries to bedroom and bathrooms, but also the pandemic with the devastating humanitarian crisis of over 160,000 people dead in nursing homes, only nursing home, before even talking about assisted living in the United States, and it's probably more because it's underreported. And infections, the risk of infection between roommates. So this is our historic moment. This is our opportunity to unlearn, to really rethink about the physical environment and what could provide dignity and safety, and also in the context of infection control and prevention. Even prior to the pandemic, there are staggering estimates of the number of elders who died due to infection in nursing homes prior to the pandemic. So I think that's our moment. This is the time when we really need a reform of the physical environment to make them truly elder friendly and dementia friendly for this population.
Yeah. Well, when you talk about infections, I think of the hospital too. You know, the transmission of infection is huge. So let's talk about some of the misconceptions of what people think they're getting into, and then what are some of the realities.
Right. So when you look at the popular media, or if you even look in research studies or even policies and regulations, the language, the words that are being used to describe this phenomenon is, I'll give you the terms, and then I'll share my thoughts about it. The most common terms are resident-to-resident aggression, resident-to-resident abuse, resident-to-resident violence, and resident-to-resident elder mistreatment. These are terms that, for the most part, are inaccurate, labeling, stigmatizing, and they're very unhelpful. In fact, they're harmful. I'm not here to say that there are no residents with or without dementia I would say it this way: there are residents that are aggressive. There are residents that are violent. There are residents that are abusive. There are people with lifelong violent tendencies that may exacerbate or change in some way when they develop dementia or after they move to a care home. But the vast majority of people with dementia are not aggressive. They are not violent. They are not abusive. And they are not trying to mistreat another individual. They're not waking up in the morning with the thought, okay, how I can harm or injure or kill another resident. There are exceptions, rare exceptions in the very, very, very early stages of cognitive impairment. So the reason why words are so important is because once we label a resident with dementia as abusive or violent or aggressive, we are much less in a position to see the human needs, the frustrations that most often underlie these episodes. And then the slippery slope for antipsychotic medication starts. And when you are sedating a person with dementia, then it is really hard to identify the unmet human needs. So they are actually giving us a gift, and they actually our job is to detect, to decode what's the meaning, what's the underlying meaning of those behavioral expressions. I'm going to pause here and we can talk about what words we can use if you want, or if you had a follow-up question about that.
Well, I think it's really important about the terms and the labeling, because one of the other things that you didn't mention that I think a lot of times families don't know is once somebody gets labeled aggressive, abusive, it's hard to even find a place to place them. Everybody's door shuts because of liability. And they're not ready to take that on. And I mean, it could be a once in a lifetime situation, but it's kind of like if your kid gets labeled in school with something, it's written in that record, and every teacher that has those expectations And, so we do have to really be careful. I would love to hear what you think are some alternative, verbiage that we can use, because, the whole psych drug thing, it scares me in a lot of ways, because I've seen it used and kind of abused in situations. Not all cases. Some people really do need that and stuff, but it is a very easy fix, especially, if there's a problem and there's staff shortage, it's drug them. And people have seen that throughout their lives in different situations. But in this case, I think it complicates things so much, and it confuses what is actually going on. And then trying to level them off, they end up in a Jerry psych ward and they have to be pulled off, and that's time consuming. We don't have enough of those. I mean, the list goes on and on and on with things like that. So I'd love to hear, what your thoughts are, first of what can we do better in terms of our verbiage and how we frame things.
Well, so first thing I would say is that language is evolving, and that's a good thing. So what I would say now, in 2, 3, or 5 years, may not be meeting the expectations then, and that's a good thing. I myself evolve with my language, with my words that I'm using, and I would say that there are people and professionals and Dr. L. Power, and I totally agree. They would say, we're not using the words aggressive behaviors in the context of people with dementia. And I totally agree. I was trying to avoid that word aggression in my book so hard and work around it in so many ways. Sometimes it worked, sometimes it didn't. But I did my best effort to avoid these terms. But some people would say, some professionals and leading thinkers would say, why even use the words behaviors, right? There was a time when we used the word behavior in a positive context, right? When someone hears the word behaviors, it sends a certain message, and we're already kind of on guard. There's behaviors, okay? And we need to control and manage them, right? And we're missing the person, and we're missing the lived experience, and we're missing the frustrations, and we're missing their desperate effort to tell us that something is bothering them, upsetting them, frustrating them, or frightening them, frankly. So, that said, you need to strike a balance, because if we're not going to use any word, then people won't know what we're talking about, right? So if I would say, these are just human expressions, well, somebody would come back and say, well, human expressions could be other things entirely. So we don't know what you're talking about. Tell us what you're talking about. So it's always striking a balance, right? But I would say this. I would say, describe what you see in a non-judgmental way, in the most neutral way possible, without labeling, without stigmatizing, without preconceived notions. So if somebody punches if a resident punches another resident in the face, you write or you say that there was a punch. If somebody trips or spits or pushes, you describe what you see. You don't add the labeling piece, because if you do, it will prevent you from identifying the patterns. And the patterns over time are the foundation for prevention. This is where the insights come from. So if you identify what do I mean by pattern? It could be temporal in terms of time. It could be spatial in terms of exact location. It could be people, events, and objects. And when you look closely, as I've done for for a very long time, when you look closely, you will see and you will focus on the interaction, not on the aggression or abuse or violence. you will be able, in 95% of the time, you will be able to identify over time, when you identify the pattern, the unmet human need that is there. And most oftentimes, it's an emotional need. It's a psychological need. It's a social need. And then there's also situations of medical conditions that can contribute to those episodes. So that's why I call it, in the title of the book, I call it interactions. I was steering away from those labeling terms, because when we use the word interactions, we have a precious opportunity to really decode and truly understand what is actually going on there. So we're in a much better position to anticipate and proactively prevent those episodes.
Well, I so agree with you. And I remember having our mutual friend on, Gert Benninger, who wrote the book Moving On by Standing Still, that talks about behaviors and what a negative term that is and how frequently we use it. And again, it's always negative. You don't get a pat on the back for that was a wonderful behavior. No, that was a wonderful skill. You know, and really, you know, breaking this down, going, these are clues for us when something is going wrong, something they're not able to communicate it, and this is how they're going about it. You know, looking, you know, getting people to look kind of at Maslow's theory at the very core of what are the needs, what are those human needs that aren't being met, and we're the ones that are supposed to be cognitively clear and capable. So it's up to us to decipher the code. So
Right.
I love the term interaction, because that can be positive, negative, you know, neutral, whatever.
And one of the people who did it the best in the country is Judy Berry. And you know Judy well. And when she used to be at Lakeview Ranch, Minnesota, the two dementia specialized care homes, and she would actually admit a lot of people who were labeled in other long-term care settings as aggressive. And she demonstrated, not only in practice, but also in research, that you are able to provide dignified care and enable people to thrive with dementia, despite the cognitive disability, when you have the right philosophy, the right approach, the right staffing level, the robust training that never ends, and when you have the resources on the ground to provide the care that proactively identifies the human needs, because it's much easier to prevent those episodes than to de-escalate them at times. So I just had to mention Judy Berry for the tremendous work that she's done in this space, and she taught us a lot, and so she deserves a lot of credit.
Yep. No, I agree. Amazing community she had built, and her, you know, training program in terms of, you know, shifting the perception of what's really going on here, and putting a magnifying glass on and going, this doesn't have to be as scary as we think it is.
Right.
You know, when we label people, you know, especially over time, they start believing they are what we're projecting them to be. You know, they're going to live up to that standard, just like our kids and teenagers and spouses and partners and friends do. So, you know, we all know that, but we have to really be conscious of what our interactions are, and, you know, what is our goal. A lot of times no one's thinking forward in terms of, are we really aligning with our mission here, or is it just an easy fix?
Absolutely.
And too often that happens. What are some of the most common episodes that you see, or causes for episodes? You talked about personal space, which I think is super important. And I think it's something we just all take for granted. And when someone is placed, they'll adjust. It might take them 2 or 3 months, but they'll just adjust. But there's no really counseling or monitoring of triggers, or, you know, it's not just, it isn't discussed usually, that I'm aware of in most places. Even when someone's being admitted to a community, I don't see families asking those questions about personal space. and what's important to them. What kind of food do they like? They might ask. But a lot of times it's not even little things like, when do they take a shower, or do they prefer a bath, or frequency? And I know those are big issues that can trigger reactions that we don't like, that we don't want.
So in terms of the causes, you need to really look at it in multiple levels. Okay. We talked a little bit about the situational frustrations and the triggers, but there's much higher level conditions that enable these episodes to occur. When you look at the organization, we can also look outside the long-term care home. Okay, what resources long-term care homes have to provide safe care in general, before even talking about this phenomena. But if we're inside the long-term care home, one of the things that you want to look at is, again, is the physical environment. The difference between a large-scale care home and a small scale living environment. We talk about elder-friendly and dementia-friendly versus not. We can go into detail about that. But then there's the staffing levels. And what I actually don't like that term, but I like the term people-to-people ratios, because these are people giving care to people. And if the needs of the people who provide the care are not met, the people who receive the care, their needs won't be met as well. Mm-hmm. So, people don't know, but this was prior to the pandemic. It's probably worse now. Half of nursing homes in America were found in dozens of research studies to be understaffed, and 1/4 to be dangerously understaffed. That means that as we speak, it's probably worse. Hundreds of thousands of people in nursing homes receive care under conditions of dangerous staffing levels that literally put their lives at risk for various reasons, let alone, even before speaking about this phenomena. So the inability to be present and to provide that supervision and to provide that proactive connection and presence with people with dementia who desperately need it, to be able to express and meet their needs. So staffing levels is a huge issue. And then is the specialized training. A lot of staff members do not have specialized dementia care training in general. And it's probably the case that the majority don't have specialized training specifically for this phenomenon. So that's another piece. This should be orientation, in-service training, and then on the floor as it happens by managers who are qualified and experienced and skilled. And the other piece is nursing leadership. You'll come in the evening and there's no managers. You come in the weekend and, there may be a manager, they're floating between care home. Staff need the support, emotional support, the guidance, and what we call experiential learning. So that's another piece there. And I would even take it a step back. One of the highest level is literally the ageist perceptions that we have in our society and the dementist perceptions in our society. What value do we have for elders in our society and for people living with a cognitive disability? And would we accept those psychologically harmful, physically injurious and deadly incidents in childcare settings? Would we put, we talked about having 2, 3, 4 residents with dementia in the same room, same bathroom. So going back to the basics, what I call dangerous normalization. We have been normalized. We have somehow accepted over decades that that's just what it is. And we're just going to live from one scandal in nursing home to another or in assisted living. And that's just what it is. And it's wrong. And my hope is that the pandemic will create the conditions and awareness for a true reform in long-term care homes, even with and without regards to this phenomenon. Other reasons have to do with the fact that this phenomenon is not being tracked by CMS. So when CMS officials themselves recognize publicly that resident-to-resident incidents are more common than staff abuse of residents. If you don't track it, for all practical purposes, it doesn't exist, and you're not in a position to learn from those incidents and develop policies, procedures, and practices to prevent these incidents. And I can go on, but maybe that's plenty for this point.
Well, I wanted you just to, because a lot of times we talk in acronyms, and a lot of our audience might not even know what CMS stands for.
Thank you. Right. So I live in that world. So it's the Centers for Medicare and Medicaid Services. And CMS oversees nursing homes across the country through what is called state survey agencies. So each state has a state survey agency that oversees the federal nursing home regulations that CMS has. And so that's kind of from the regulatory oversight enforcement aspect of things. And what happens that when these incidents occur, and if they violate one of the federal nursing home regulations, the state surveyor may substantiate the allegation, and they may issue a citation. But the problem is that then they spend many hours to conduct the investigations or the standard surveys. And then there's an investigation report, and there are thousands of those reports that are sitting at state survey agencies and CMS. And they're under broad categories of abuse or accident, or several other what is called FTAGs, State Survey Deficiency Citations. And I'm not aware that many people are looking at those investigation reports. If you had one FTAG or sub-FTAG, we would in one click be able to pull together thousands of those investigation reports specifically on this phenomenon, and be able to be in a position to learn from those incidents to inform prevention on a large scale. Instead, they are buried in those investigation reports, and they're just gaining dust, and we're not learning. So this is a huge missed opportunity at a time where CMS is aspiring for more efficiency in oversight, prevention, and enforcement.
Right. I have lots of comments on what you said. When you were talking about staff ratios and said, look at it people to people, I think one of the things that people don't understand is the importance and the impact that employees have that might not be dementia specific, from the front desk to housekeeping to maintenance to laundry to food service. These are people who don't have to interact but choose to interact, and they're having real conversations. And I have seen they just adore a lot of these people because they see them as a person and they're having real conversations with them. And I think most families will see, depending on what level someone's living at, but like a life enrichment or activities person, they see them as really dealing with them on a person-to-person level and having fun and being engaging. But somebody, and again, this you can't just pigeonhole everybody in there, but like, let's say somebody giving meds, a lot of times they're handing off a med looking for their next person because of the time crunch. And so, and some do a really nice job in terms of interacting, but what an interaction really is or means or feels like to somebody, I think we really overlook. Just those
I think
small
this
little
is,
things.
I'm so glad you brought it up for a couple of reasons. The first reason is because, and I write about it in the book extensively, if somebody would ask me, what are the three most important words in long-term care homes? If you want to provide dignified, safe care and to enable residents with dementia to thrive, the three words are close, trusting relationships. So, and that's where everything starts and ends. And some of the most enlightened care homes in the world, in fact, there's one in Australia, and I believe you know, and I hope I pronounce her name well, Daniela Greenwood.
Mhm. Oh, yeah. Yep.
She may have moved from that care setting, Helensville, I forget.
Yeah, she's independent now.
Right, but she talked about the number one item on our mission statement is close, trusting relationships. And when you and when you work very hard to build it and nurture it, you are in a big position to provide dignified, safe care and to enable people to thrive emotionally, psychologically, socially, spiritually. And when you don't have it, and it's also easy to damage the trust in one interaction, you can destroy the trust, you know. So when you don't have it, it opens the door for a whole host of care-related problems, including this phenomenon. But going back to, and that also has to do with knowing the life history, you know, to the fullest possible, and finding those gems throughout the life, even from childhood and young adulthood, that can enable you to decipher and decode those human expressions in the here and now that are often being taken out of context. But to your point, you know, what we call the non-direct care stuff, but oftentimes the housekeeping, the maintenance, the dietary, the people who work in the kitchen, the people at the front desk, many times they interact with residents with dementia, and they need to be trained to the fullest possible, not only orientation, but on an ongoing basis, because many times staff are busy doing something else, and it's the maintenance person or the housekeeping who's actually interacting with them, or have to actually running into an episode between roommates. And it takes time to get another staff member. They need to do something beyond alerting the staff immediately. There was a very tragic case in Canada in a nursing home near Toronto many years ago. There's a whole inquest about it, a big investigatory report trying to understand what happened there, where a resident was admitted on a Saturday at noon, and at 7 p.m., two of his roommates were dead. He injured them severely and they died. He managed to cross the hallway and starting to attack another resident in his 90s, I believe. And it was a housekeeping personnel that happened to be there that managed to de-escalate it, possibly saving the life of that third individual. And then when the inquest delved into the details, this admission should have never happened. Should have never happened in general, should have never happened on a weekend. And there was a history for this individual that should have been, the admission team should have looked very carefully into, and he should have never been admitted. I can't tell you how many times, whether it's a manager, owner, or administrator, would say, "Oh, if we would have known the background of this individual, we would have never admitted him after the fact, after another person was injured or died." So yes, these non-direct care staff doing a lot of direct contact. So they're absolutely critical in general, and especially in the context of prevalent understaffing. So we really need to lift them up, support them, compensate them better, recognize for their efforts. I remember this front desk woman who shared the same cultural background with a resident with dementia who was in advanced stages of dementia. She would engage in those episodes on a regular basis. She and only one other staff member were the only ones who were able to de-escalate those episodes when this resident engaged with those episodes with other residents. When the other staff member that was the only one who was able to calm her down was not working on a shift, it was only the front desk woman who walked in. The second the resident saw that woman, she immediately calmed down. It was just stunning to see that, because there was something they connected at some deep level. They shared a cultural background from a country of origin and the language. And it was just stunning to see that immediate positive effect on this resident.
Well, and sometimes that outside person can see things too. I remember my mom in the nursing home one time, there was one, just darling, a little Asian woman. And yet at mealtime, she would just cause a ruckus because of what she was perceived to do. So the staff would go around and they'd put the napkins and the silverware on top of the napkins and be setting the tables. And she'd go around and she'd grab all the silverware. And they would get so angry at her. And so I saw that a couple nights in a row, and I just thought, oh, this is just ridiculous, you know? So I went up to the woman and I said, do you want to go for a walk with me? And so we just went for a walk outside the room. And next thing you know, we're holding hands as we're talking, and we come back in. And during that, and her English was very broken, but what I got out of her was she was trying to help. Her family owned a restaurant and she used to roll the silverware. What an easy fix. What an easy fix to let her feel purposeful. And again, you've got to worry about the infection control, and you can't necessarily use those things, but she was trying to help, and she was perceived as really just being this disruptive monster because they were, tight on time and everything. So and I want to say, I love your idea about including those kind of outside staff, those support staff in training. I think that is so overlooked. And I love the practice that some have, and not too many, where once a week or even if it's once every couple of weeks, where they have to spend, every staff person has to spend 15 minutes one-on-one with a resident, just to remember why they're there, who's paying their paycheck, and that these are people, and you can have a great interaction even when someone's nonverbal. There's different ways to communicate. So the other thing I wanted to mention was you had talked about the levels of training, the orientation, the in-service, the on-floor. And I have heard of a couple of companies that have really, with COVID especially, and staff shortages, they were really having trouble with incidents. And they were getting complaints from families on this. And so they decided to hire basically what I would call a mentor in motion that was on the floor. They were at a supervisory level, but they were there really just to support and help and guide on a daily basis. That was their whole role. And to me, I thought that was brilliant, because staff do need that support. So many of them, they're worried to complain or ask a question because they don't want to lose a job, or, and they want to learn, but they need those outlets. Right. So lots of good information. And then last, when you had talked about Daniela Greenwood, one of the things that hit me hard in one of her videos was she said, every person has a right to citizenship. And just because they're living in a community doesn't mean they've lost that. And just in the beauty. And for me, I learned personally with my own mom, and I think we don't see this really until we're slapped in the face or something significant happens, but we get so task oriented. And this is families and in communities both. But we get so task oriented, we're not seeing the person anymore. And for me, I had to step back one time when I snapped at my mom for repeating herself, which is a really common thing for people with dementia to do. And I felt horrible. and I thought, I have to do this different. And instead of being driven by that to-do list, if it's a job description or if it's a family person doing tasks, and say, I need to reprioritize. And for me, the priorities was she safe? Was she happy? Was she pain-free? And when I looked at those things first, I interacted totally different. Totally different. And it was just a really simple thing to do. But I think so often when we're talking about shifts and changes, everybody thinks it has to be so heavy and they can't handle it. But we all know it's the little things in life that make the difference. And, you start doing a lot of those little things and you get more people doing them, they become natural. And you add to it, on a gracious, timely fashion, instead of a lot of times we just slam the hammer down and go, okay, nothing's going to be the same. And that's where you get everybody nervous and quitting. And all of a sudden you're starting from scratch with that. So what are some of the main barriers that you see for prevention? Because I do see that whole change and, we can't, we just can't do that. Or the saying I hate the most is, well, we've always done it like this. That one just puts me through the roof,
Yeah, I just want to mention something real quick, and then try to answer your question. One of the things that came out in 3 research studies, you had talked about dining room situations, and many times it's just this mundane, just situation. A resident will try to grab food from another, or or invade a space of another in the dining room, and one of the important messages that I want to kind of share is what we started with, is that 3 research studies have shown, 2 in the United States and Canada and Australia, shown, including mine, looked at the circumstances surrounding fatal resident stress incidents. So I looked at 105 fatal resident stress incidents, and I published an article about it. And strikingly, in the United States, Australia, and Canada, what was found is that when I was curious about what was the physical contact in those incidents that led to the injury that ended up in a death. It was what we called push-fall incidents. That, again, we talked about one push is enough. So it goes back to the normalizations that, elders can't harm each other. Look at her, she's so frail, she can't do anything, right? But all you need is one push. Really, their bones are not as strong, and their ability to protect themselves is not as robust. And so I just wanted to kind of share that finding, that it was between 40% to 60%. So one study showed 40%, now one shows 60% and 50%. So roughly half of fatal resident stress incidents were found in 3 research studies to be the nature of the physical contact was a push. Pushing somebody away, it's like, get away from me, okay? Like somebody enters the personal space and stays there. Somebody in advanced dementia. And the person, say in the early stage, whose space is invaded, he or she may be at first tolerant and understanding, and they would say, I really need my space. I would like to have my meal right now. I don't feel comfortable, but staff are inside bedrooms. And then you see how the emotions build up. Mm-hmm. And then at some point, the resident may reach a breaking point and they may push the person away. And that's all you need. That's all you need. So I just wanted to kind of make sure that it's in there, because to kind of raise awareness of staff members that it doesn't take much for injury and then a physical and psychological trauma, and then there could be a decline and fatality and a death, which could be absolutely devastating and tragic for the person and the family, who are often shocked to learn that these incidents even occur. So I just wanted to kind of share that. But you have asked about some of the barriers. And I think, we touched upon some of them, whether it's what is the value that we have for elders in society at the highest level and for people living with dementia. I think that's where the conversation needs to start. We need to tackle head on the dangerous normalization of these episodes. You'll have residents themselves internalizing those perceptions, saying, oh, we were bitten in elementary school. What do you expect? That's always the, or nurses would say, well, it happens every shift. Nothing changes. We report, and nothing changes. So this normalization, like this always happened, it happens, it will continue to happen. And I'm saying this is wrong. This shouldn't happen. You can reduce the majority of those episodes and keep not only residents but also staff safer. So that kind of at the high level. So the barriers frankly, is the decades-long pushback from the long-term care sector with regards to staffing levels. We know it's the number one issue. So that's a barrier there. Extreme lack of specialized dementia training, not only nursing home, but assisted living as well. There are ridiculous requirements in many states in assisted living for staff training, and this must change. And so you have the staffing, you have the training, the nursing leadership is critical to sustain processes, to make sure policies and practices and procedures are adhered and fulfilled. Shifting from labeling to learning. When I reviewed for 10 months, I reviewed the communication log. There was a lot of labeling there, a lot of labeling language that we spoke about earlier, and it was rarely the case that something positive was written. So it's all kind of unbalanced, right? Tell us what works and document it so others will learn from it as well. We need to change the physical environment. It oftentimes contributes. So many times staff members will complain, we can't supervise the residents when there's long hallways and then there's an L shape. We can't even see them at the end of the hallway. There's no way, or so the layout needs to be thoughtful. So for a good example is the greenhouse floor plan. In Tupelo, Mississippi, there's a floor plan of the first greenhouse in the United States. So you have 10 residents, private rooms, private bedrooms. There's no nurse station. It's a living space around a hearth, around a fireplace. It's the feeling of a home. It doesn't feel and look and smell like a hospital. It feels like a home. And so the ability of staff to supervise residents and detect the early warning signs of distress, anxiety, and frustration is critical because they can see from almost every point, they can see the residents as they move around the space. Okay, so that's a huge piece, a real reform in the physical environment of spaces. So, there's other issues, but I think the bottom line has to do with with dignity. And that's why I called our document, I'm going to put a plug here, if that's okay, for our documentary film that I did with Judy Berry, and we called it Fighting for Dignity. So if you want to summarize the book in 3 words, it will be fighting for dignity, because people with dementia sort of fight with each other, so to speak, in order to preserve their dignity. And when you look at the dictionary definition of dignity, is the state of feeling worthy, esteemed, and respected, basically. And when people with dementia feel that their dignity is threatened or at risk, they respond with those human expressions, with those behavioral expressions. And they're basically giving us an opportunity to understand what underlies it, how we can prevent it. So dignity is at the core of this phenomena and the ability to preserve it proactively.
Yeah. One of the key things that you mentioned was, made them feel. And I think we have to get that has to be in the core of the mission, is making them feel even comfortable to be there, being part of a community, and then utilizing all of the senses. It's not just the building layout, it's a lot of different things. And many of these things can be changed very easily. I mean, from noise levels to layout to lighting to color choices to types of furniture that doesn't aggravate or hurt them when they're trying to get in or out. I mean, it's endless what we can analyze. And I loved when you mentioned about the charting, noting those things and suggesting how do we improve these, or noting, like I always think when it comes to the quality control reviews, we're not going to shift their perceptions if we can't shift our own, if we can't tell them what's really important to the people we're serving, and show them the brilliant moments. But instead we highlight typically all the negatives because we're busy covering our butts. And there's got to be a balance there. I could talk with you, as you know, all day long. So I want to wrap up with asking you if there are main things that you think a care home can do to reduce any incidences that we haven't discussed so far.
Well, I think we kind of did. I think we kind of talked about those big blocks of the perception of elders, their value, the people-to-people, safe people-to-people ratios, specialized training, the nursing leadership, the role of the social worker that should be a critical piece there, the training of the robust training of direct and non-direct care staff, awareness of owners. That's another piece I would add there. Not just the administrators, but corporate office, if it's a chain, but owners. Owners need to understand, they understand the risks, because nobody wants to have a tragic incident in general, of course, and to be on a homepage of a major or local newspaper, and then there's liability. There's 2 cases in California, resident-to-resident fatal incidents. One ended up with $1.2 million loss. That was the verdict, and then another one was $1.9 million. So now, and by the way, these 2 reportedly occurred in the same chain. So now we're talking about $3.1 million. So I'm saying, can we dedicate a fraction of that towards staffing and specialized training and prevent a trauma and tragedy and devastation for the family? In our film, Fighting for Dignity, that folks can access it, rent it, or buy it on Terra Nova Films. We interviewed 3 family members that were had their loved ones injured psychologically, sexually, and physically severely during those incidents. Because we wanted to move, to write an article is one thing, to share statistics is another thing, even to write a book is one thing, but to actually sit down and listen to those family members and the far-reaching, devastating impact on them when they were so shocked to learn that their loved ones were injured so badly in those incidents. Maybe that will resonate with certain providers, with owners. Better to be proactive and preventative and anticipatory, to use an anticipatory care approach than to end up having a severe injury or death and then deal with that. So that would be a message for owners and administrators of those care homes.
Yeah, I guess I would like to add too that I think everybody thinks they're doing this, that their communities are welcoming, engaging, and fun, but I don't think that they ever really survey that in terms of, and especially in this time of staff shortage, do the staff feel that way? Or is it just a task? We get into these routines where what was once fun because of micromanaging is now high pressure. And when we do that, it changes the whole interaction. And I think that has harmed us on multiple levels in terms of delivery of service. And so, using those words and having that as a mission is one thing, but we have to dive deeper and not just have it look pretty on an ad, and having an engaging, fun place where people feel that they're part of a community, but actually talk to people and see how we can improve, because that's where your ideas are going to come from, to improve. You shouldn't be scared of hearing the negative, because that's the only way you can address it, is knowing about it. And so part of that is removing that. Well,
I have to jump in and forget to say that I forgot to mention one of the biggest and most important pieces, which is personally meaningful engagement. That's one of the biggest secrets in the prevention of these episodes. Not only about bringing joy in the moment, but also when residents. So I followed 12 residents with dementia for 10 months. And with the highest level of distressing behavioral expressions, we selected them very carefully for 2.5 months. We would do screening until we identified the 12 with the highest level of behavioral expressions, according to many staff members. And when they were bored on their own, not doing nothing, a whole host of problems occur, including those episodes. And when the same 12 individuals were engaged in music therapy, with pets that are trained, with the toddlers that walked in, aromatherapy, movement and dance, being out in the beautiful garden, just sitting and looking at the birds. And so, when they were engaged, you saw dramatic reduction of those episodes. So I would say, if you're an owner of a long-term care home, invest in your recreational therapy department, or whatever you call it, life enrichment, invest in it. And get the best director of recreation therapies that you can get, train them, get the best people you can, pay them well, support them. There's a lot of turnover in that sector. And when you do it, you can not only bring joy and meaning and purpose and enable people with dementia to feel useful, you will guarantee reduce the vast majority of those episodes in the public spaces of the care. They still need to deal with a lot of between roommates and bathrooms and all we talked about earlier, but you will really make an impact there beyond giving joy and to enable people to thrive and have meaning and purpose in their lives. So I had to kind of share and add that piece.
No, that's good. And the other thing I would add to with the activities in life enrichment is you have to respect them. They are not very well respected in the industry. They are looked as less than from a director level, and yet they are one of the most impactful positions in your community. And that needs to be raised and changed. And there's so much you can learn from them, because they spend the most time with people. So their insights are so great. But again, we could talk forever. I want to wrap this up. And again, Eilon, just thank you for your time. Again, his book is called Understanding and Preventing Harmful Interactions Between Residents with Dementia. The Health Professionals Press website, we'll put that down for you where you can get the book. If you want to visit Eilon's website, you can go to dementiabehaviorconsulting.com. That's dementiabehaviorconsulting.com. And if you'd like to reach out to him via email, it's Eilon Caspi, EilonCaspi@gmail.com. Again, thank you for the great work you're doing. And it's just such an honor to call you a friend and a colleague. And again, I'm just thrilled that you've got this all pulled together.
Thank you, Lori. I would say thank you so much for inviting me to do it today. It's been a just pleasure as always. We've been working together for years. And I would just leave the viewers with one thought. Please remember, these are people, individuals living with a serious brain disease who are doing their best to cope with a situation that could be distressing, frightening, and frustrating. So they're really, really doing their best. And when you look at the interaction, you will see that there's a tremendous opportunity for prevention, for enhancing their dignity, their personhood, their identity, and their safety. So thank you so much for joining us today. And thank you, Lori, for all the incredible work that you're doing over the years. You've been really leading the way in giving true voice to people living with dementia. And I'm so grateful for what you've been doing for so many years. So thank you so much too.
Right. And to our listeners, I hope you enjoyed this program. Please like, click, and share. I think there was a lot of gems in here. And again, don't forget to run out and order that book, Understanding and Preventing Harmful Interactions Between Residents with Dementia. Until next time, bye-bye.
Thank you, Lori. Take care.